So you want to become a pediatrician. You love the idea of babies, children, and adolescents. Who needs adults anyway? Let's debunk the public perception myths and give it to you straight. This is the reality of pediatrics. Dr. Jubal, medschoolinsiders.com. Welcome to our next installment in So You Want to Be. In this series, we highlight a specific specialty
Let me
within
know
medicine,
in the comments
such as
below
pediatrics, and
what
help
branch
you
of
decide if
medicine
it's a
you are
good
most
fit for you.
interested in.
Pediatrics is the field of medicine providing care for babies, children, and adolescents from birth up to the age of 25. The age range was capped at 18, but given our new understanding of human brain development, the age range has been expanded.
So I just want to clarify that if you go into residency for pediatric, the oldest you will see is typically 18. Yes, there's a lot of things that are happening from age 18 to age 25 that are related to development, but in terms of the age range that you're going to be expected to see, it really does cap out at 18. I mean, you just kind of have to keep that in mind that, sometimes you might see people that are older than 18, but generally you do not.
Think of pediatrics as the equivalent of internal medicine, but for younger patients. That isn't to say that children are just little adults, because they're not. Children's physiology is different, and certain medications you would use for adults may have dangerous side effect profiles in children. Additionally, because children are more resilient than adults, they tend to crash hard and abruptly, meaning...
Yeah, this is like 100% true. Children, they don't really show a lot of symptoms when things are really wrong. Like you might see like something is a little bit off, but when children get really sick, they have this capacity to really kind of tough out their illness until the very end where they crash and burn. So anytime a child is sick, you really have to pay attention to everything that they are doing, all of their vitals, if they're peeing okay, if they have a temperature, because you just never know with kids. They will surprise you.
They may seem relatively okay and stable, followed by a sudden decompensation requiring prompt intervention.
So I actually have a story about this. I had a child that was admitted to our general pediatrics team for what we thought was bronchiolitis. So it basically like inflammation of the airways. This was like a child under the age of 1. Through a process of unfortunate events, the child ended up passing from meningitis. So we didn't know that the child had meningitis until the very end where he was kind of crashing and burning. It was a very odd situation because typically you tend to see these like signs that kids are going to get worse. But like I said, this child, for whatever reason, was not showing any other symptoms. I feel like anytime something bothers you about like how a child is presenting, you want to maybe just look into it a little bit more, because even if they're not showing signs, there might be something kind of brewing.
Just like internal medicine, pediatrics is a massive field with a variety of subspecialties such that it's difficult to generalize the field. You can take care of patients in a variety of settings, from premature babies in the NICU, to healthy children at regular PCP visits, to hospitalized children for various rare genetic anomalies. You can view pediatrics from a generalist versus a specialist lens. As a generalist, you'll be handling a wide variety of presenting pathologies that don't require subspecialized care. If you practice in the inpatient setting, this translates to being a pediatric hospitalist, taking care of kiddos admitted to the hospital. This may include infectious diseases like pneumonia and cellulitis, neonatal issues like hyperbilirubinemia and failure to thrive, or metabolic problems like diabetes, amongst others.
This slide here is definitely the bread and butter of inpatient pediatrics, looks like.
If you're an outpatient generalist, you'll be seeing patients in clinic, primarily for regular checkups, vaccinations, and less acute conditions like allergies, eczema, constipation, or ADHD. As a specialist, you focus on a single organ system of the body. Similar to internal medicine, this could be cardiology, gastroenterology, rheumatology, endocrinology, and others. Neonatologists specialize in the care of neonates, which are infants less than 4 weeks old. In outpatient adult medicine, the majority of your patients have comorbidities, meaning pre-existing medical conditions or risk factors. In outpatient pediatrics, the majority of your patients are well children, and you'll primarily be focusing on health promotion to prevent rather than manage a diagnosis. You'll build a relationship with the patient and their family over time, as you may see them for up to 25 years through all developmental stages.
I think this is like a really important thing to remember is that as a general pediatrician, you're mostly seeing well children. The work that goes into it is sometimes just as challenging as managing someone who is 60 years old and has 5 different comorbidities. And the reason why pediatrics is difficult in this aspect is because there's so much work that you have to do with the parents in terms of educating and in terms of reviewing what works best for their children, and then you have to get them on board to the plan that you feel is the best for the child. I mean, you're doing a lot of, maybe you're not doing as much medication management, but you're doing a lot to prevent disease down the road, which I think to me is more meaningful sometimes because you get to see that your work kind of pays off down the line.
Beyond well child visits, you'll see the occasional asthma, eczema, or failure to thrive, meaning poor weight gain. From time to time, you'll see a rare diagnosis like leukemia or retinoblastoma, but these are exceedingly rare in primary care outpatient settings.
It is cool to find a diagnosis that is rare, but as a general pediatrician, you don't get to manage that, but screening for that and looking for those signs and making sure that this is not happening in your well child is a very arduous process. So, you kind of have to pick your battles in terms of what you like.
You'll still need to be alert, as kids can compensate well and look healthy until they suddenly decompensate. Outpatient pediatrics has a great work-life balance, and you'll generally work 9 to 5 hours. It's common to have 4 days of clinic and 1 admin day per week.
I think this is like a really great pro for physicians who, they like being doctors, but they don't want their whole life to be about being a doctor. So having that clinic schedule of like 9 to 5 is really nice because that means you're not working long nights, you're not coming in on the weekends, and you have 1 day of kind of doing your admin work, or if you work in an academic institution, you might be doing a little bit of teaching. So that is a really nice thing if you're an outpatient doctor.
With inpatient medicine, your focus is on kids who need to be admitted to the hospital. You'll admit patients from the emergency department, working them up with labs, diagnostics, imaging, and other tests. For certain conditions requiring specialized care, you'll send consults to the specialist for recommendations. In adult medicine, you often have disposition disasters, meaning a great deal of frustration in discharging the patient and getting them to a place that can take care of them, whether that's a skilled nursing facility or someplace else. However,
some things that they don't tell you in medical school, or you may or may not see, is the fact that these adults have to go somewhere after they get discharged from the hospital. I mean, you can't just put them out on the curb. You have to arrange for them to be taken care of when they're discharged. So that means that you have to make recommendations for like their nutrition, their activities, their medications. It's not like that in pediatrics. I mean, once a child gets better in pediatrics, they're discharged home, they go home with their parents.
Situations can still be complex with kids, such as when they aren't safe at home with their parents. In these instances, you'll interface with social workers and child protective services.
You have to remember that the person who is suffering the most is the patient. In this situation, it's the child. So your job is to advocate for that person who cannot advocate for themselves. And I think there's like definitely some parallels here with the adult world. So there's just different situations.
Academic pediatrics often includes 12 to 18 weeks of inpatient care. Beyond clinical practice, there's a high amount of research and teaching in addition to side projects of various types. These are wide-ranging, such as quality improvement for implementing a different electronic medical record in the hospital, or partaking in advocacy and going to the Capitol lobbying for better safety protections for children. Community pediatrics is the most common practice setting where you're working in a larger medical group. Private practice is the least common, as it is for other specialties, in part because hospitals are buying up small private practices. Some think that pediatrics isn't that complicated, and it's just babysitting. That's certainly not the case. And remember, kids actually have a unique physiology that requires careful attention and nuance. If you think pediatrics only includes talking to children, think again. There's a heavy family relationship building component, and you'll essentially work with at least two patients, the kid and their parents.
Some people think pediatrics is like, oh, you see a lot of healthy children and that's it. But it's not like that. I mean, you would know that if you ever did like NICU or pediatric ICU. Kids can get really sick. It can be really difficult to kind of get them back in a sense. I mean, I think in the NICU, one of our patients lived in the NICU from the time they were born up until almost they were like 2.5 years old, because this was such an incredibly sick child with so many different complications. So yeah, it's difficult to have to go through that.
Last, some think pediatrics is a women's field. And while the majority are certainly women, it's not as skewed as some other specialties. Approximately 70% of pediatricians are female.
I think there's probably several reasons for this. I just want to say that if you are a male and you're interested in pediatrics and you think like, oh, maybe it wouldn't be as good of a fit for me because it's mostly females, I would disagree. I feel like a lot of the great mentors that I had in residency for my pediatrics rotations were actually male. And I think that it just, no matter who you are or how you identify, I mean, if you have a passion for helping children, you should definitely give pediatrics a second thought.
After medical school, pediatrics residency in the US is 3 years. In residency, the focus is on inpatient, but there's of course continuity clinic where you'll act as the primary pediatrician for your panel of patients.
Yeah, so during my residency, I always had at least 1 half day of clinic per week. And me being med peds, I saw a combination of children and adults, but my categorical colleagues, they saw all children, and you get to have patients who you establish care with your first year, and you get to see them grow during those 3 years.
You'll get new babies when starting residency and have them for 3 years, offering a longitudinal relationship that many enjoy. As with most residencies, the hours are challenging, usually ranging between 60 to 80 hours on most weeks. It's not too far off from something like internal medicine.
That's a very typical amount of time to be working in a week.
A chief year, meaning tacking on a 4th year to your residency, is optional and is best suited for those looking at academic positions who want to strengthen their CV and leadership experience.
It depends on your program. A lot of times the chiefs are selected by the faculty. So it's not like if you want to do chief, you're going to be chief. Like you kind of have to stand out a little bit more, work a little harder, express your interest in being chief and your interest in going into academics.
In terms of competitiveness, pediatrics is in the bottom 4, with an average USMLE Step 1 of 228, USMLE Step 2 CK of 245, and a match rate of 98.2%. But of course, highly desirable programs are more competitive, even if the overall specialty is less so.
Also, it has to do with the fact that general pediatrics is one of those specialties like we cannot survive without. So I think that's probably why the bar is a little bit lower, just because if you think about it, our country needs general pediatricians. We need to keep producing pediatricians, so it's kind of in the best interest of hospital systems to continue to match each year.
Stereotypically, medical students applying to pediatrics are the soft, gentle, kind-hearted students who care deeply about the community and kids. They tend to be positive and want to come to work smiling and laughing with their patients. These medical students are stereotypically the do-gooder types.
Yes, I feel like most people in pediatrics are very cheery, very nice, very polite, very, just nice as opposed to some other specialties. I wouldn't say that all pediatricians are necessarily soft personalities. I definitely have met very strong personalities. And I think this also comes with experience and with kind of the level of acuity that you're dealing with. So our pediatric intensivists tend to be more intense. I would say they have more of the stronger personalities because, they have to be very decisive people. They can't be soft when they are in critical care. So I think that's a relative term. I wouldn't say that if you are someone who is not necessarily described as soft, it wouldn't be for you.
After pediatrics residency, there are several subspecialties you can pursue through fellowship. All of the following are 3 years in duration. Hematology oncology, or hemonc for short, is focused on treating kids with blood or solid cancers, including leukemia, lymphoma, brain, and the like. You'll also deal with non-cancerous blood disorders like sickle cell disease. It's primarily, but not exclusively, an outpatient specialty. This is for the pediatricians who are a mix of brain and heart. They're able to be there for their patients on one of the worst days of a parent's life, while also being highly intellectual and strategic about the best approach. This also tends to be a highly academic subspecialty.
One of the pediatric hemonc doctors that I worked with, she would always say, if I'm seeing a patient in the hospital for the first time, usually it's because I'm about to tell them the worst news of their life. And she said, I know that the family's falling apart, but I know I have to be the one that can't fall apart. I'm the one that has to keep it together. So I think that takes a very special person, and I have so much respect for hemonc doctors for that.
With many PhDs. ICU is exclusively inpatient in nature, unlike the other fellowships listed here. You'll be dealing with critically ill kids. Instead of focusing on diagnosing conditions, your primary aim will be to stabilize and support them for other subspecialists to take over and follow up with. You'll be dealing with sick kids who are intubated, meaning on breathing tubes, on pressors to maintain blood pressure, and will help with pre- and post-op surgical care. It's primarily acute conditions, but you'll see some frequent flyers, such as patients with cerebral palsy who are in and out of the ICU often with infections. This is for the pediatricians who are the masters of physiology, remembering everything from medical school and applying it to the ventilator in front of them. They want to do the fun stuff of treating the physiologic abnormality and then transferring to the next level of care without getting into the nitty-gritty of diagnosis and follow-up. Cardiology is the most competitive pediatric specialty, and many do additional fellowships after to further subspecialize within cardiology, like electrophysiology. Those that specialize in heart failure will find themselves dealing with lots of heart transplants. You'll deal with lots of congenital abnormalities, like the tetralogy of Fallot. In managing these congenital conditions, you'll work closely with cardiothoracic surgeons to determine optimal timing of repairs.
Yeah, so I've been posting some day in the life things here on YouTube and TikTok. So if you're interested more in what goes on day to day as a pediatric cardiology, definitely check that out. I would say that everything he said is very true. I mean, you get to see a lot of congenital anomalies with children. Interestingly enough, in Mississippi, I have seen so many patients with double outlet right ventricle, which is diagnosis I didn't see as much when I was training in Missouri. So I don't know what it is about this part of the country that we have so many double outlet right, but definitely still see tetralogy, truncus, hyperplastic left heart. The pathology that we see here is just so varied. I don't think there's any of the congenital cyanotic diseases that I haven't seen, and I've pretty much seen every acyanotic lesion already in my residency. Another thing that he was mentioning was that pediatric cardiologists have to work really closely with cardiothoracic surgeons because cardiology, what we do, goes so much hand in hand with what the surgeon has to do. So our job is to know everything there is about the anatomy of the heart and the hemodynamics of the heart. So when a surgeon goes to fix the heart, they have all of the information that we have helped to provide them, and they can plan accordingly for their surgery. It's very difficult when something is unknown or something is questionable. The surgeon goes to open the chest and then they find something that was not previously found. It can change the entire trajectory of the child's surgery, or it can change their prognosis. So cardiologists specialize in definitely laying out the structure of the heart and determining how the changes that the surgeon will make will change the hemodynamics of that heart after surgery, and anticipating those things so that we can best help them after surgery as well and help our critical care team manage those things.
Sometimes it's a staged repair requiring one surgery at 6 months, another at 1 year, and so on. Stereotypically, these are the pediatricians with a bit of a god complex who love managing complex physiology and nerding out about physics.
I have to disagree. I can't think of anyone that I work with who feels like they have a god complex. If anything, I feel like everyone in pediatric cardiology is very much humble about what they know and what they don't know. Because the thing with pediatric cardiology is we have so many ways to prove what we think is happening in the heart. I mean, we have Doppler, we have catheterization. We need to know the exact pressures and volumes and all of these things about the heart. So it's very hard to say, oh, I know this for sure, but I don't have evidence of it. Yes, we do like complex physiology. I feel like that's a given when you work with the heart, and physics, in specific fluid dynamics and electrophysiology. If you don't like physics, I would definitely say, maybe don't go into cardiology. I mean, I love physics when I was in school. I was never like the best student in physics, but I loved it. And once, you put that into the heart, it makes it even more exciting.
Gastroenterology is a highly procedural subspecialty, splitting time between inpatient, clinic, and the procedure suite for endoscopies and liver biopsies. They primarily deal with chronic diseases, like inflammatory bowel disease, thus promoting longitudinal relationships. But there's much more to it than that, such as getting into the mind-body connection, as there's a large overlap with psychosomatic disorders in children, such as anxious kids with abdominal pain. Nutrition is an increasingly important focus, as we are in a child obesity epidemic.
Yeah, so this is very true, and it kind of highlights the fact that there's soon to be a lot of overlap between gastroenterology and cardiology. And the reason being is that, we're seeing younger kids getting more adult-like problems of the cardiovascular system because of their obesity, namely hypertriglyceridemia or high cholesterol, basically, and high blood pressure. So those are the things that kind of go hand in hand.
Biome and intestinal immunology. Pediatric emergency medicine can be approached in one of two ways: as a 3-year fellowship after pediatrics residency, or a 2-year fellowship after adult emergency medicine residency. There's no outpatient time, no following up on labs, and once you get your shift done, you don't have to take any work home with you. Your job is to stabilize kids and get them to the appropriate level of care. Compared to adult emergency medicine, there's less acuity, but when it does escalate, it escalates quickly. If you want to know more about the field of emergency medicine, we did a So You Want to Be episode on that. Pediatrics is a great specialty with lots to love. First, and most obviously, you're working with kids, and you get to joke around with them and be silly every day at work.
I love working with kids, so I definitely agree with this. I mean, it's just so nice to walk into a room and to see a child who knows you, who likes you, who is happy to see you, who's silly, and you get to see them develop, you get to see them say their first words and things like that. It's very cool. And then children are just naturally loving. I think more so than adults. I love it when randomly I'll get a hug or a high five, or someone will want to share their snacks with me. It's just like little things that children do that they show kindness, and I feel we in in healthcare, I feel like we need more of that. So it's very refreshing to me.
It's unique in that you can make an impact early in someone's life that can compound to yield tremendous changes over a long period. It's a beautiful part of the field that's unique to working with a pediatric population. This is the most powerful form of preventative medicine for the simple fact you're intervening early in their life.
Yeah, that's very true. One of the things that I thought about in this aspect was about my own pediatrician growing up. You know, I only got to see him like once a year, or when I got sick. He would always just chat me up and be like, what do you want to be when you grow up? And all these things, like what activities are you doing? He always encouraged me to be active, to eat healthy, to work hard in school. It made me feel better when I would go in next year and he would be like, oh, how'd you end up doing in that math class? Or how's your serve doing in tennis? He would remember things about me like that. And it would just reinforce all those positive things, those positive behaviors that I had developed in my life. So I think that was definitely special.
There are subspecialties of pediatrics that don't have great outcomes, like pediatric oncology. But for the most part, the majority of your patients will get better. There's less death compared to adult populations, and rosier outcomes are always a good thing. There's a high amount of flexibility within the field, meaning it's family friendly. After all, these are the doctors that prioritize children. Even in residency, your program will be more understanding of maternity or paternity leave than something surgical.
If somebody was pregnant or their child was sick, I think everyone was very understanding of those situations, because I think more people had kids in pediatrics, whereas like in my internal medicine side, not everyone had kids. Even attendings, I feel like, were not as understanding of this sometimes. Internal medicine, it's like, you're here to work, like you gotta keep going, and you kind of have to just work around your day to get all of the other things that you need to do as a parent.
While pediatrics is a great specialty, it's not for everyone. Compensation for pediatrics is at the bottom of the list, averaging $232,000 per year. Part of this is the payer mix, as many children are on Medicaid, which has lower reimbursement than commercial insurance. In the fee-for-service model of US healthcare, you'll generally have fewer interventions than adults, which is another reason why adult specialties often make more.
Yeah, so this is definitely true. It has to do with the fact that kids are generally healthy, they don't have as many interventions, therefore the hospital doesn't necessarily make as much profit from pediatric care. Again, this can vary depending on the market that you live in, or if you are in private practice versus working in academics. So
if you love high acuity and the adrenaline rush, pediatrics has less acuity than most other specialties, since kids are usually healthy and resilient. As with other primary care focused specialties, there's lots of charting and computer time, and you may feel like you don't get enough time with your patients. Seeing child abuse and maltreatment, or seeing young children pass, also never gets easier. And finally, there's not as much research within pediatrics compared to adult medicine, which can be frustrating since certain drugs haven't yet been tested in kids for efficacy and safety profiles. How can you decide if pediatrics is a good fit for you? While you should certainly love children, you shouldn't mind having essentially two patients. After all, you're dealing with not only the kids, but also their parents, who may be more concerned or neurotic with their child's health than with their own. Pediatricians also tend to think about the health of the whole child, including nutrition, living situation, families, and thinking broadly about what health means more so than just diagnosing and treating conditions. Many pediatricians find enjoyment with the data, puzzles, and detail required of the field. They tend to be interested in public health and advocacy work and are focused on more than just the medicine aspect, but also the context in which the child grows. In doing so, they hope to build a better system to promote children's health. And finally, the happiest pediatricians tend to be mission-driven. After all, it's not a lucrative specialty, and many who go into the field do so because they love kids and want to take care of them at the end of the day.
Definitely lots of advocacy and community work opportunities within pediatrics. I would say that this was not my favorite part about my training. I guess for me, it didn't feel like I was actually being a doctor, which, you know, not every doctor does the same thing every day, but I felt like compared to my internal medicine training, I was lacking that, and I felt like I was doing more work than that was not related to medicine. So I would say that that's probably one of the reasons I didn't go into general pediatrics at the end of the day. So that's it for today's video of Medical Insiders. I thought it was a really good video. It was very informative. I think there's so many things that you have to consider when you are making your decision about what kind of residency you want to go into. And if general pediatrics is one on your list, definitely leave a comment below, or if you have any questions about residency, make sure to drop them down there as well. Make sure you like, share, and subscribe, and I'll see you in the next one. Bye, guys.